First, just thank you all so much for having me. It's really nice to sort of be here with all of you today, and I just want to again appreciate Andy Parado and Aaron Cruthers and all of their input and important role in our Community Vaccine Advisory Committee. So today I can just give you a quick overview, kind of where we are as a state with our the pandemic itself and sort of the state of the pandemic, and then I know we all want to talk about vaccines. And as mentioned, there's been a lot of shifting just in the last day or so, and certainly over the last several days, and I think more to come, which we absolutely want to continue to engage the disability community and all of you in the conversations to move forward. So with that, I'll just sort of launch in, and then again, hopefully have a good dialogue after that. So yes, as mentioned, we'll talk about the EPI just briefly, some safety and considerations, and our rollout and distribution. So this is just, our dashboard, and many of you who may have come to the COVID-19 dashboard can see kind of our overall cases, deaths, and test positivity. We also have other data on there that has to do with hospitalizations and intensive care units. We have reached over 3 million cases in California. And sadly, as you can see, over 37,000 deaths, and actually have been looking more at excess mortality rates as well, that I think we'll be able to share the actual data on very soon. But I think we've seen a lot of excess mortality in 2020 related to this disease. So this is just sort of what we call our epidemic curve. So this kind of shows you the course of the disease over, 2020 essentially, and then the beginning of this year. And you can remember and see in July was when we had, a really big, what we thought then was a really big surge. At that time, we had probably around, at the peak, it was in the teens as far as the number of cases per day. And then we, saw that subside. We held tight with some of the things that were happening there as far as restrictions, had closed several things down. And then at the end of August, we initiated our blueprint for a safer economy, where we had our tiers, which you're likely very familiar with, the purple, red, orange, and yellow tiers. And over time, I think that things were pretty stable, as you can see. And then starting in, things started to increase just a teeny bit in October as we were gradually reopening. And more counties were able to open more things and more things indoors. And then we started to see some increases in November. We did what we called an emergency break, meaning any counties that were starting to go in the wrong direction as far as their case rates and their test positivity, we moved them back more quickly to the more severe restrictions. But another week or two after that, we realized we really weren't slowing things down as much as we needed to. So we actually did the regional stay-at-home order based on intensive care unit capacity as we saw our hospitals starting to fill up on December 3rd. So that's what this other orange line is. And then we've had, really quite intense surge over the last several weeks. But thankfully, we do believe we're over the worst of it. You can see these peaks here. January 4th is actually the second sort of large bump there, and that was what we think has been our highest peak. This curve looks at when testing was done or when people report their first symptoms. So it's not when we get the test reports, which is sometimes a little bit delayed. So again, we do think, as you can see, that we're looking that we're hopefully on the other side of this, and that we've seen and we do think the regional stay-at-home really helped prevent more of a holiday bump from people gathering and traveling. And the reason I think you see this dip in that orange line of the 7-day average is a lot less testing during the Christmas time period. So with that, just to kind of move right into vaccines, which I know is what you really want to hear and talk about. So right now, there are 2 vaccines that are available for use in the United States. There's the Pfizer BioNTech vaccine and the Moderna vaccine. There's several that are in phase 3 clinical trials in the US that we are hoping will come, for emergency use authorization as soon as March is what we've been hearing. AstraZeneca vaccine, the Janssen vaccine, and Novavax vaccine. And I believe either AstraZeneca and or Janssen, again, may be applying as soon as March for emergency use. The really nice thing about the Janssen vaccine is it's 1 dose instead of 2 doses. And actually really quickly on the other 2, both Pfizer and Moderna are 2 doses. So one of them is 3 weeks later and the other one is 4 weeks later. So as far as vaccine safety, it's been really important to us in California to make sure that, especially I think given the last several months and the Operation Warp Speed and concerns that the public had, amongst others, about, are things being sped along too quickly? Are there any steps being skipped? So we're really lucky here in California to not only have great groups like yourselves to advise the state and the public health department and the health services agency, but we have a lot of experts that are on national committees that have to do with review of safety of vaccines. So some of the academic scientists that are physician scientists actually are on both the FDA committee as well as the CDC committees that review, again, both the scientific safety as well as some recommendations about allocation and priorities. So we have a scientific work group that really is looking at that FDA data and any publicly available data to make sure, again, that they can advise us that they think all the normal steps, while they have been expedited, but that all the normal steps to assess vaccine safety have been done, and also to really look at making sure that appropriate numbers of people were in the trials and how that was broken down. So a diverse community in that scientific safety group. And they have definitely confirmed that the biotech and Moderna vaccines have met high standards for safety and efficacy. There are some very normal side effects that can happen after vaccination, often more after the second dose versus the first dose. Sore arm, aches, fatigue, or fever for a few days after getting the vaccine. But again, those resolve. And the way I often describe this to people and to patients is it actually means your immune system is starting to respond and really learning how to respond to the vaccine to protect you again in the future when if you're exposed to the infection. And here's more of the details that I was starting to talk about. So the biotech, Pfizer is approved for 16 years and older, 21 days apart. They both have 94 to 95% efficacy after the 2 doses. The Moderna vaccine is approved for 18 years and older, for 2 doses given 4 weeks apart. And then it's also really important for people to realize, even after individuals are vaccinated, they do still need to keep wearing masks, washing hands, and watching their distance until the vaccine has been widely distributed. We're trying to come up with our goals as far as how many Californians over the age of 16 we can get vaccinated over time, and trying to look at projections and supply. But until we really get to that level of what we call community immunity, we don't know for sure yet. We do know that individuals can be protected from infection or more serious infection, but we're not sure yet if they, especially with this disease where we're finding that many people can be infected and not have symptoms, we don't have evidence yet that it's protecting people from becoming carriers that can infect others. So that's why everyone needs to continue to do these measures. So the other things that are really important to us in California as we have planned for the distribution administration is to have 3 key values that we are and guiding principles. So transparency in bringing our community stakeholders together, safety requirements that I have already emphasized, and then distributing and administering equitably at first to those with highest risk of becoming infected and spreading COVID-19, as well as those with the most serious mortality and morbidity. So some of the key goals, again, overall have been to evaluate efficacy and safety, establish the Community Vaccine Advisory Committee, and then the drafting guidelines work group has been the one that's developed a prioritization framework allocation plan that has engaged stakeholders and the public, and they used the national frameworks as a guide for California, and then tried to, based on local data and looking at population numbers and other data we had in California and any data we had, they helped devise a prioritization framework, and then to poise our system to be ready. Sorry, that's my puppy who is having a dream in my home. That we were ready to distribute and vaccinate once vaccines are available to California. And then again, equitable allocation. And then really importantly, employing an effective communication campaign to ensure public trust and appropriate messages. And that's where we've really, again, been very grateful for the Community Vaccine Advisory Committee to be partners in that, amongst others. This is sort of an example of just sort of how, and this is from actually the national academies, I think, had developed some of these slides to think about, over time, how will vaccine distribution look, and how will things change as we get more vaccine over time. So we're very much in this very early stage here of limited doses are available. We have a very constrained supply. So really, we've been trying to target administration to achieve coverage in priority populations. So I think, as many of you know, what the initial priorities were healthcare workers who were exposed with occupational exposure, and also people who live in nursing homes, as well as the staff in nursing homes, because that's, again, where we've seen a lot of spread of disease and a lot of the highest number of deaths. We also, have been working to examine and look at, and I think where we're still, as I talk more about some of the recent pivots, I want to really get more dialogue with all of you about how we look at people with high-risk conditions and how we kind of address that with some of the changes that we're doing. I think as time moves on and we get more doses available and we get more supply, then we can increase access to other persons in congregate settings and other sort of general population. We don't have any pediatric data yet for children, so that's really going to be much further down the line. And eventually, when we get to excess supply, we'll be able to shift to a more routine strategy. But we definitely are several months from that, as far as we know. So looking again, I already mentioned the first phase 1A was where the first target priorities were, and that was estimated in California to be about 3 million people. And to give you a sense of how many doses we've received so far, I think we are around 4.5 million doses that we've received here in the state. So that's really only covering about 2.25 million people. And we just got our allocation for this week, and it's still under 600,000 doses for this coming week. So we're really getting, I think it's ranged anywhere from 200 to 500,000 doses every week. We hope with the new administration that there's going to be a real emphasis on doing everything we can to increase supply, but right now it's really trickling in. So the other priorities that got announced around mid-January, January 12th, were prioritizing individuals 65 and older, and then based on available supply, prioritizing and targeting outreach efforts for people within that group over 75 years or older, occupational risk exposure, and then residents in vulnerable communities as determined by California Healthy Places Index or local health department knowledge. Actually, what we need to be adding to these slides moving forward are really also healthcare provider knowledge around, again, people with disabilities and or other medical conditions. So the other sort of principles that have sort of evolved over the last couple of weeks as we've been learning lessons about vaccine distribution are making sure that with all the special needs for this vaccine, being able to administer it as quickly as possible into the priority groups, but also not wasting any vaccine. So we had heard a lot of our early tiers, even within that first phase of healthcare workers. We had a lot of careful deliberation on who are highest risk even within the healthcare workers and distributing that. And it sounds like it was really slowing down distribution, which is of course not what we want to do. We really want to get as many people immunized as quickly as possible with the doses we have, knowing we still have limited supply. So there's just other principles here about making sure that those doses don't go to waste and that you're continuing to offer to people if you feel like you've offered, especially in small jurisdictions, to your population that's eligible initially. So this is where we are actually as of yesterday, that we had administered over 2.5 million doses here in California. And I believe we're getting close to almost 500,000 individuals who've gotten their second dose. So getting close to 500,000 who've been fully vaccinated. So the other 200,000 or so have had first doses. And again, as I mentioned, we've only really received about 4.7 million doses so far in California. So again, a really small proportion considering our state of 40 million. And then this slide, again, over 7 weeks, essentially, is when we've gotten these 2.5 million vaccines in. We had a 10-day challenge as we realized things were very slow early on, and there was a lot of ramp-up time, I think, between the holidays, the medical surge, getting used to this new vaccine, and also physical distancing and observing people after the vaccine. but we've had a huge, increase in capacity and tripled our pace of administering the vaccine over the last several weeks. So at one point early on, we were only vaccinating about 40,000 people a day. And most recently, it's been 125,000 every weekday for sure. And this is an illustration of that. So you can see early on, much slower pace as things were getting ramped up, as people were kind of getting things moving. And then over these last couple weeks, we've really increased the capacity and pace. And what we've also really learned is that there's a huge data lag in when these doses are administered and when they're entered into this data system that we're trying to use to track. But that has been, I think, a huge lesson learned for us and a huge effort we've been really working to emphasize. On one hand, a lot of administrators are focusing on getting vaccines into arms and not necessarily data entry. So that is an understandable goal, but it's really made it difficult for us as a state and for you and the public to understand how, are there vaccines being used efficiently and effectively? So that's really been a huge effort of the last several days as well, improving our data. Sorry, this is a little bit repetitive here. So lessons learned over the last 7 weeks again. So we really learned that, as I was starting to allude to, that we really need to simplify the vaccine eligibility framework, especially again, given that we're trying to do a combination of having vaccines distributed within the healthcare system and also at some of these mass vaccination sites for various other persons, again, because a lot of these mass vaccination sites can really, once they get up and running, can have a high throughput, but it's also harder to assess eligibility when you're trying to have priorities. And then I already mentioned, again, we've had a lot of challenges standardizing the vaccine information and data. There's actually a data system that needs to be inputted for the federal government. It's called Vaccine Finder for inventory. We have a California immunization registry, but there's also 2 other immunization registries, one in San Diego and one in San Joaquin Valley. So trying to make sure all of those centrally are coming into one data point that we can really track across the state. And then again, addressing supply, I've already emphasized that quite a bit, that what we really need is more vaccine to be able to get it to more people. And that is really one of our biggest constraints as well. So the big sort of news in the last couple of days is that, traditionally the way this has worked and the way it worked, for example, in the pandemic during 2009, is that the federal government would allocate to the state health department. The state health department would then allocate to the local health departments, who then, for the most part, most of the allocation decisions were made at that local level. So there's 61 local health jurisdictions in California. We do have a few what we call multi-county entities. So health systems like Kaiser, Sutter, Dignity, some of the larger health systems that are in at least 3 counties also had some direct allocations from us. I think what we're learning is we really want to really shift the administration to the health system and the network that is really good at administering and operationalizing a large sort of operation like this, and really shifting a lot of the public health resources to be really thinking about policy and reaching our most vulnerable populations and our most disproportionately impacted. So this is literally, there was more details about this at noon. This is from the slides that Secretary Galley and Secretary Richardson did at a noon press conference today. And I think since you all have been in a meeting all day, you probably haven't gotten to see it. So I'll just tell you a little bit of the highlights of kind of what's to come. So we are going to build instead this administration network that will be overseen by a third-party administrator, actually, that the state will contract with, that has expertise and experience to do healthcare and vaccine distribution. So we're really going to hold this new third-party administrator to more efficiency and greater visibility for all of us to see kind of where the vaccines are more centrally, rather than this distribution across the 61 local health jurisdictions. The public health departments will absolutely be part of that network, and will still be doing a lot of their really important work, and again, be able to emphasize more of their focused work, while a lot of the logistics and operations will be dealt with by this third-party administrator. So the network will include everything from our public health departments, pharmacies, again, the larger health systems, public hospitals, FQHCs and community health clinics are going to be crucial partners as well, and then still ongoing sort of pop-up and mobile sites. with an immediate focus on allocating to those who are vaccinating quickly and safely to accelerate our progress. And again, allowing us both at the state public health and local public health level to really focus on disproportionately impacted. So I think mobile sites and or mobile vaccinations are really important, I think, for the community that will want to work with all of you about thinking about operationalizing getting vaccines to people who are, it's much easier to bring vaccine to them rather than having them come to some other site, whether that's a clinic or a mass vaccination site. So again, as our supply grows, we'll be expanding fixed and mobile sites, and again, having public health departments really work at the local level on how to engage and again, focus on the communities they know that are harder to reach. So we'll be looking at equity in many different ways. Many of you have heard about the Healthy Places Index, which looks at low-income neighborhoods and compensating providers in part based on how they reach underserved communities. And again, really, we've been talking a lot to some of you as your key leaders about part of equity certainly is people with disabilities. So I think, again, we're going to have a third-party administrator focus on, age-based allocation for the most part, and then really being able to focus with a lot of our other efforts on how to reach, again, people who are hard to reach and that are high priority for both because either disproportionately impacted, I think, is a key theme. The other things just to quickly mention are that there's some new technology tools too that the state is implementing. So there's going to be a new statewide tool that is easier for providers to maintain records and report the administration of doses quickly. So this is something that was underway. It's called CalVax, but it's really just gotten off the ground in the last week or two. So continuing to make sure we're shoring that tool up to, again, improve our data visibility at all levels for vaccine administration. There's also a new website that just started piloting this week called My Turn. And over time, as more and more populations are eligible, people can enter information to learn if it's their turn and get notifications when it is. So it's being piloted right now in LA and San Diego, and then other counties can opt into this in coming weeks. Once again, because we have such limited vaccine supply, there are just not enough appointments yet for even all of the people that are eligible now. But over time, we anticipate this will become more robust and valuable, especially for more of the overall general population, notifying Californians and enabling them to make an appointment. Again, I think we really want to emphasize that some of this will be able to address a lot of the general population and allow us in public health to focus on other unique populations or populations that need, have different needs, such as yours. And again, we'll be working closely with you on that. So overarching, I think, again, some of the themes as far as the shift are that nothing should slow the administration of vaccine doses. The most important thing for us collectively as a community to get community immunity as soon as we can, and really balancing safety and speed and equity while scaling up to meet the level of vaccine administration needed. So I will pause there. And again, I think this is all evolving very quickly. I think we want to work to engage, sort of simultaneously this new administrator, really focusing on a lot of larger systems, but then I think it'll allow us to also have incentives that we work in for that administrator and public health departments and the state public health department and other state departments actually as well, to be able to work with communities such as yours to make sure we are able to allocate and deliver vaccine to other populations where it's needed. So I'll pause there, take some questions. Yeah.
Dr. Pond, thank you so much. That was very helpful. You covered a lot in a very short period of time. And I see there are a number of council members with their hands up. Charlotte, could you let Mr. Chair know who is up and in what order?
Yes, I'd be happy to. Thank you, Dr. Pond, and thank you, council members. So I received I saw a message in the chat box from council member Nicole Adler. So we'll begin there, and then we'll be followed by council member Andy Imperato and Chair Wesley Witherspoon, and I have two others behind that. So we will start with Nicole.
Nicole, you're on mute.
Nicole, you're never on mute.
I'm just excited for this. I am here to advocate for all people with disabilities to get a COVID vaccine so we won't get COVID in the first place or die from it. we, the disability community, do not want to be a number in a hospital or in a bed with COVID-19. So can we please be a priority to get a shot sooner than later?
Yeah, I think again, what we are aiming to do, and I think it's gonna happen sort of simultaneously, but is we're kind of building this more centralized system to deal with making things simpler. But I think will also allow us to spend more time and energy while that third-party administrator is doing some of the logistics to really work with your community and other communities where we want to deliver a vaccine, and we need to do it in a way that isn't necessarily the traditional system to do that, and how we can do that most effectively. So I will absolutely acknowledge this is still rapidly evolving and needs to be work in progress. The good and bad thing about the small vaccine supply is that it's taking us some time even to get vaccine, even to that, even the healthcare workers, right? We still haven't even necessarily gotten all the healthcare workers who help take care of all of us vaccine. So we're working on that as well. But again, I really appreciate this partnership and the Vaccine Advisory Committee to work and engage. And I think what we're really realizing as well is we want to have some other smaller kind of work groups with key stakeholders like yourselves to really figure this out, and what are some of the operational issues we can look at statewide to address specific communities.
Thank you, Dr. Pond, and thank you, Nicole, for your questions and comments. Did you have anything else to add, Nicole?
What can I do as an advocate to push this community to get the vaccine? Because I'm an equal rights advocate, and I can make videos as well, and I can do whatever I can to get this community tired of COVID. So that's what I'm asking.
Yeah, no, thank you. And I think we're all really tired of COVID. This is actually the 1-year anniversary of, I think, the first cases in California. And just a few days ago was the 1-year anniversary of the first cases in the US. And I think all of us are really tired of COVID, especially some of us in public health. So I think you're doing, by being part of this council, you're a great advocate. And I think, again, Mr. Moreno and Mr. Carruthers are great advocates on your behalf. And I think, I think this conversation is just one of many that we aim to have with all of you to again, figure out really how we effectively deliver vaccines to persons with disabilities, including, again, aligned with the healthcare system. But I think my hope is that with this other approach that we really work on some of the unique ways we need to get vaccine to other populations while we kind of simplify some of the other operational logistics as well.
Thank you so much.
Sure.
Thank you. All right, I'll move to our next person on our list. Councilmember Andy Imparato, please.
Yeah, I'll be brief, but thank you, Dr. Pond, for making time. We know how busy you are, and we also appreciate that you've made time to have a smaller call with the disability advocates on the council last Friday. So I just had kind of 3 quick suggestions and welcome your feedback. One, on Nicole's question, am I right that it could be helpful for Nicole to do a video where she talks about the importance of getting the vaccine? Because I feel like part of your goal in working with the advisory council wasn't just to figure out prioritization, but also to have trusted messengers deliver a message about safety to others who they have credibility with. So I just put that out there. You might want to take Nicole up on her offer when you guys get to the point where you're trying to bring in more people from the IDD community to get the vaccine. And then on the announcement that the governor made today, Dr. Pana, we really appreciated on Friday, as we told you, that you were unequivocal and crystal clear, as you were today, that disability is part of equity. That's really important. But when you guys did your announcement today, and I realize you may not have written it, it specifically says the new approach will continue to focus on equity. Vaccines will be allocated to make sure low-income neighborhoods and communities of color have access to vaccines. And then there's a reference to underserved communities. We know, based on what you've said to us, that we're part of underserved communities. But the more you can actually say people with disabilities or people with high-risk disabilities or whatever terminology you feel comfortable saying, that will really matter in terms of us really understanding that we are being talked about as part of the equity. So I just put that out there. Again, I realize you probably didn't write this, but just, trying to drill it into the people that are writing the messages. When you talk about equity, you talk about communities of color, also talk about people with disabilities. And then the last suggestion, which may not be a good idea, but I just had it, so I'll put it out there, is if you have a bunch of people over 65 driving to Dodger Stadium or wherever they're driving to get the vaccine, can you make it clear that if they happen to have somebody with a disability in their household with them, that it's okay for them to bring their disabled family member with them to get the vaccine at the same time? Because presumably that's a streamlined way for some people to get vaccinated. There's a lot of older folks who are taking care of their own relatives who are adults with intellectual and developmental and other types of disabilities. So there may be a way to kind of do the whole family at once. And I just put that out there as kind of a safety valve that you guys might be able to implement without creating a lot of complexity.
Yeah, thank you for all those comments, Andy. In reverse order, I think that's definitely an intriguing option that we, I think we have been talking a little bit about that, admittedly more at an informal level, but what does the provider in the moment do when, whatever the example is, one of their household members or whoever accompanies them is also might meet the criteria or will meet the criteria very soon, and why not just vaccinate them at the same time? It's more efficient for everybody. And I'll also just say anecdotally, I think that's happening, and I think the tough part about from the policy level, I will just sort of acknowledge to you all, is that so I do think that we're trying to build in that flexibility, but also have policy level when you look at the overall numbers in the population, and that you're not kind of opening a new huge number to increase the demand with a small supply. That being said, I think, in a segue to your other comment, I think we definitely need to do a better job, I think, messaging around disabilities being part of equity. And also for the rest of you, I think actually, I don't know if we had a chance to talk about this even on Friday, but the Surgeon General has also been a champion for all types of equity, including disabilities. And I think one of the ways we are looking at as we develop accountability for a third-party administrator and then all the other providers, we're looking at ways we can incorporate equity into that. And one of the measures that you've heard us talk about in other frameworks, like with the blueprint, is Healthy Places Index. And there was a big crosswalking that a lot of our health department epidemiologists did, and the Office of the Surgeon General did, to look at different vulnerability indices, and some that are known more for including persons with disabilities or not. And when they crosswalked it with HPI, sorry, excuse me for my being home with my dog. But when they crosswalked it, it really did have a lot of the same, it overlapped with the same sort of, when you look at it geographically, like the Healthy sort of Places Index really did crosswalk well with people with disabilities too. So we haven't 100% landed that is the metric, but because we are using it for another, state framework, we're very likely to land on that. But I do want you all to know both those things. One, that it crosswalks well with, I think it's called the SERGO, or the other Social Vulnerability Index, that does map really well to persons with disabilities, and that we're working on how to hold both providers and this larger party administrator on certain equity measures that will incorporate that. And, and we will definitely be looking at, with an eye to, again, the different kinds of equity we're looking at. So whether it's race, income, disabilities, all of those things. So, and again, some of this transition will take time. So I want to continue to engage with all of you about, again, the devil's always in the details, which many of you on the Vaccine Advisory Committee have brought up as well. And I think we want to really understand and work with both at our level and with our partners on the local level who are actually administering more directly, how to overcome some of the barriers that are there for getting vaccine out. Another question? Yeah.
Yes, thank you so much. The next person I have in line is our council chair, Wesley Witherspoon.
Hi, Dr. Pond. How you doing today?
Good. How are you?
I'm doing good. So COVID-19 affected me in so different ways. I lost an uncle who was the first, unfortunately, the first fatality in the state of Mississippi. And I have cousins out in Mississippi that cracking corona, and my friend cracking corona. And I know 3 self-advocates that lost their parents due to COVID. So I've been affected a lot. I've been affected a lot with COVID. And in fact, my wife and I, we live in separate homes. And her house, someone came on COVID-19. So she had to quarantine her parents' house for 14 days. So my concern is 61% of people with disabilities live with their families. So it could be intergenerational. So it could be 20 something or 50 something or 80 something. So a lot of people are with the elderly. So I suggest that we vaccinate people with disabilities along with their family members. And with my family, I live with people over 65, and trying to get a shot is, might as well play a lottery. It's been that hard. And I'm gonna keep it short because people with disabilities should be very high in line, because a lot of them has pre-positioned conditions. In fact, one of the self-advocates I spoke to, he's over 75, had a pre-positioned condition, he had got COVID. So it's very important that people with disabilities are vaccinated, and there's a lot of people with medically complex conditions. So it's very important that we vaccinate people with disabilities, because a lot of people with disabilities, they need a vaccine. That's it.
Yeah, thank you for your comments, and I'm very, very sorry to hear about your losses. I think the other thing I didn't mention, but I think there's an upcoming policy update, especially for the vaccine administrators, that will talk about some of these high priority categories, but also say that healthcare providers, and again, it won't address all of the barriers, because again, coming into the clinic or the doctor can sometimes be a barrier, but healthcare providers can vaccinate, people with, I have to relook at what the language is, and it'll be posted very soon, I think, but around, healthcare providers can vaccinate persons with underlying high-risk conditions. Again, I think the dilemma that we continue to straddle with this is all of these different communities, right? And a scarce resource, and how to kind of have this combination of allowing discretion, like, now a couple of you have brought up sort of household numbers or family members, and we absolutely know in other communities at risk, there's a lot of multi-generational households where there's a lot of transmission, and balancing, again, household numbers, which certainly is more efficient, with those within the household who are at the highest risk of again, death or hospitalization. But I do anticipate that part of the guidance to the actual providers is going to allow a lot of discretion for persons with underlying medical conditions, including disabilities.
Thank you, Dr. Pond. Thank you, Council Chair Witherspoon. Next, I have Council Member Joyce McNair, please.
Okay. Thank you, Dr. Pond. You mentioned, and also was on the screen, that the Janssen vaccine is probably going to be approved in March, and it's only 1 dosage. Now, my question is, because it's 1 dosage, does that mean it's stronger and there is the possibility of more side effects or stronger side effects, or has that all been addressed in the trials, those issues?
Yeah, that's a great question. And I think that will be part of the evaluation before it will be authorized for use, right? So when they apply for that emergency use authorization. And so the FDA will be looking at that, and then our scientific safety group. I will admit, I have not personally yet looked at a lot of that data. I've been trying to participate in our scientific safety groups where they talk through some of these things. So I actually don't know yet, but I think that's absolutely all part of the considerations. And then I think the other thing that, there will be those important questions about efficacy, side effects, and then I think it'll be a really interesting question as well. It'll be so much easier, right, logistically, if it really is only 1 dose and has equal efficacy. And then when that's a new scarce resource, but additive, who are the right populations to, prioritize using that 1 dose regimen for? So that'll be something I think that we will likely have the drafting guidelines workup look at as well, and be needing to make some decisions about, and again, engaging the Vaccine Advisory Committee as well on those decisions.
All right, thank you. I just wanted to say the reason I asked that question is I have multiple injections in my eye, and anytime I can avoid more
it's fine with me.
Yes, I understand.
Thank you, Councilmember McNair. Next is Councilmember Sandra Aldana, please.
Good afternoon, Dr. Pond. Thank you so much for joining us. It's really great to hear everything that your commission is doing for us. I have a slightly different perspective. I worked for the first 15 years of my career in public health, starting back in the late 80s, and I worked on HIV during the time that we were working on developing vaccines, developing therapeutics, and the like. And so I look at COVID or SARS-CoV-2 as very similar to how we evolved in the treatment and etiology of our understanding for HIV. So, and I've also worked internationally. So all of that informs my questions and kind of how I got to them. So I'm hoping that that gives you a little bit of a framework. So I have three. My first is, do you think that there is a reason that people with disabilities, including those with intellectual and developmental disabilities, are not being moved to a higher priority? Is that potentially being influenced by this very strong voiced anti-vax movement that has occurred over the recent past? I know several of my local legislators and legislators throughout the state, and potentially individuals that are now at a federal level who have been lobbied by these anti-vax movements. Do you think that that is at all impacting how the messaging gets sent by this community, as in it is not a unified voice the way we saw back in the late 80s, where everyone was on this bandwagon, everyone wanted to move things quickly. You had very disparate groups that were unifying together to create one voice and one message. And when you're hearing different messages, because we don't have a centralized public health system, I think that creates a lot of difficulty to move things forward and to actually see progress. My second question is, given that this is not a typical vaccine in that it's not grown in a lab, right? It's not in an egg solution the way we're used to other vaccines being developed. Is it reasonable then to surmise that individuals are more likely to suffer really serious complications from contracting COVID than they are from the side effects of this vaccine? For example, individuals I'm thinking that have either brain or spinal involvement in their disabilities, somebody who's having 100 seizures in a day versus, you know, somebody who has cerebral palsy and has had epidurals and in the recent past, these types of issues. And then my third question is that, is it possible in that guidance that you keep speaking of to provide sort of a framework for how our individuals can receive the vaccine? You mentioned a little bit about the mobile units, but really to provide a framework that can be expanded upon by our local public health entities. I do a lot of work with our county public health. I actually interned with our county public health back in the day. And I think they need guidance as well as to how to address special populations. I already know of healthcare workers that have been exposed to COVID and tested positive after receiving their vaccine. And the only exposure they had was at one of these, you know, huge fairground events where there were a ton of people waiting in line. You were outside, but you were waiting in line and you had testers in one line and vaccine people in another. And so there tends to be a lot of interaction between those two groups. And is there a way that for this particular community, other than mobile vaccine clinics, so to speak, is there a way that we can look at offering more concrete guidance for local municipalities as to how to do that more effectively for this particular community?
So a lot of questions. I'll see if I can try to answer them. And actually, I think I will need to peel off after I try to answer these. But so I think your first question had to do with, do I think anti-vaxxers have impacted advocacy for vaccines? I think that was part of your question. And I think the anti-vaccine movement in general and vaccine hesitancy has definitely, yes, I think has been certainly a huge part of the equation as far as vaccine hesitancy. And actually a lot of that movement was, that's not really your question, but just to quickly comment, ends up being kind of anti-public health, right? Like a lot of those, that movement has really moved to, and don't wear a mask and don't, answer the phone if you're going to be, you shouldn't be isolating or quarantining. The government can't make me do that kind of thing. I don't know that it's impacted advocacy as much. I think there's been a lot of advocacy, which is, again, admittedly, a lot of, again, the dilemma. There are a lot of different communities who are at high risk for different reasons, right? And trying to look at the best data we have. And again, weighing this balance of risk of exposure and risk of serious disease. And, when those two cross, those are the highest priority potentially, right? Those were things that the drafting guidelines work group looked at, like if you're at high risk of exposure and high risk of serious outcomes. So, an elderly person with underlying medical conditions who also is still working, in a healthcare facility, in a nursing home, right, would be the highest, and just trying to work through those different things. So I don't know if it's impacted the advocacy, but I do think it's just, again, a balance of different kinds of advocacy and different kinds of conditions and competing, every, I think, again, it's a scarce resource that multiple different communities and populations would like access to, and we need to get access to, and just trying to squeeze blood out of a rock is kind of how we're feeling right now. I definitely think, for your other question, that the benefits definitely far outweigh any risks of side effects for this vaccine, and for actually all vaccines for that matter. I have not seen anything around any medical conditions that under which, even for people, I think the one thing that has been coming up a lot is, you probably heard in the media, people who have allergies or have had anaphylaxis to other things. It's still thought that, on one hand, those people should get their vaccine in a clinic where they definitely have epinephrine and all the medications and support needed, but that the benefits, again, still outweigh the risks, so that you can get through that. You can get epinephrine and go home and be fine. And then you're protected from the really serious, hospitalizations or intensive care unit or death that can happen with COVID-19. So absolutely, I think in all populations that I'm aware of, the benefits outweigh the risks. And then a framework for local health departments and more guidance. I think that is another thing we are hoping to spend, again, more time on, and also sharing a lot of lessons learned. I think, as you may know from your own experience and others in general, with whichever field you're in, right, there might be one health department that's doing one thing really well and another one doing another. So being able to share lessons learned, so that whichever health department, and actually that's another thing maybe you all can help bring to us is, we know that, this health department's really good and have a really good framework for reaching people with disabilities. And we would love to know that and help share that across other provider and across this new third-party administrator to get vaccines, again, into people's homes. I think it's not even just a mobile clinic, but really having people come to homes, I think, is another thing we've kind of put on the list of things we want to make sure can happen, which definitely would address, I think, a lot of the disability community's needs.